May I welcome Professor Derralynn Hughes, who's a Professor in Experimental Haematology and Honorary Consultant Haematologist in London. Thank you for joining us.
Thank you so much. Thanks for the invitation to talk and to discuss with you our clinical pathway management for anaemia. And this has been developed as part of our clinical pathway group strategy at the Royal Free London. And our aim was to improve the quality of life in patients presenting with anaemia by effectively and also efficiently increasing their haemoglobin. So we started by mapping our current state, and this is a year or two back now, and I suspect a situation which is recognised as somewhat common to all of you. So we found that a number of areas across the trust were managing anaemia. So preoperative assessment, our renal clinic, gastroenterology, obstetrics, elderly care and the medical unit. And that was across our different sites within the hospital group at Royal Free, Barnet and North Middlesex. Each of them had developed their own pathways for anaemia with some common facets to it, but some unwarranted variation. We also looked across the number of blood counts that were coming across our group in a month. And at the start of this pathway, we found that we had nearly 500,000 full blood counts per month, representing 200,000 or so unique patients, of whom 3.8% were anemic. And so the scale of this problem and potentially its public health implications for the feeding of patients into various other pathways is really important. So this is where I was describing the different groups who feed into that pathway. Hope you can see that one. Somebody could let me know if it's now changed. Yeah, wonderful, thank you. So these are all of our different anemia management pathways, and we mapped those. And so patients were coming into various services within the hospital, and they received a referral, they were being triaged, going into the clinics, having the relevant history and examinations, some further investigations. Some of them would then go straight to follow-up, others would have more tests, and they would go round this circuit, sometimes for many months or even years without effective management of their anaemia. If you go into the various clinics around the hospitals, you'll find that there are algorithms, all of which are internally appropriate, but without a coherence across the different units. So the care of the elderly medics would have one algorithm, we'd see something else in the haematology clinic, something else in preoperative assessment. Some of that variation is warranted. So we may have different cutoffs for people going for complex surgery compared to those in the maternity clinic. But some of that management is unwarranted and would lead to better efficiency and management of patients if that was removed. So with our various teams across the trust and with patient input and co-design, we developed a new pathway which was streamlined. It was effectively patients would have a referral made. Our navigator would look back and see whether any blood tests had been made. And if the patient had already had blood tests either on the referral or on our system within a pre-specified length of time, then we would not request other blood tests. Otherwise, they would come into clinic and have blood tests prior to their arrival, and then have management on the same day with the potential for iron deficiency anemia to go and have an iron infusion if that was indicated on the same day, whilst the cause of their iron deficiency anemia was managed. But importantly, you can see that we also move the patients off into 5 or 6 other pathways, depending on the combination of the MCV, the haemoglobin and the haematinics, so that we wouldn't be having prolonged investigations of patients who might have a B12 or folate deficiency, or equally of patients who actually needed to rapidly get into a haematology clinic to have a bone marrow examination to look for hematological causes of their anemia. Our initial approach to ensuring that this pathway was actually managed in a way that was consistent across the different sites and different clinics was to embed it into a booklet. And so we had teams working through the booklet, which I admit was a little time consuming and laborious, but as they got used to it, it speeded up. And the booklet was effectively a flow chart which can enable us to dry test with our patients whether the flow of going from an MCV down into hematinics and then consideration of whether somebody had anemia of chronic disease or moving across into a renal clinic and so on actually worked from a flow point of view. We also developed a hematinic cue card, which all the people working in the laboratories will be really familiar with, which gave us standardized advice to give out to teams on the basis of various hematinic and iron interpretation. And the important thing for us, this was also internally consistent with the pathway that we developed within our booklet and within our clinics, because what we were finding is that often people would ring the laboratory for advice around hematinics, but it may not be consistent with the advice that they would have received if patients came to the laboratory. Again, both sorts of advice are correct and appropriate, but just some unwarranted variation there, which did leave potentially to some confusion. In addition to this, we also created standardized prescribing. So we find that a number of our patients coming to clinic who'd had trials of oral iron and failed them because of intolerance or insufficient increase in the hemoglobin required iron infusions. And patients receiving iron were often given an arbitrary dose of an iron infusion because that was the prescribing with which the physician or clinician prescribing with them was familiar. And that meant that on some occasions, patients were receiving one dose, which was convenient to come up to clinic to receive a dose of an iron infusion, but that wasn't necessarily a total body dose. And so within a few months, they would be anemic again and requiring access to the service. So we took the algorithms and equations for iron prescribing and embedded them into a pro forma, which would then enable us to prescribe the 2 doses that were required or a series of doses depending on the appropriate type of iron infusion that was being given. This in itself turned out to be a real enabler of having same-day iron infusions for our patients who'd had their blood tests. They would come to clinic, required iron, and they could go straight to the day ward because the pharmacist developed sufficient confidence in this algorithm that it took the pharmacist out of that prescribing and it could be delivered by nurses from ward stocks. We use patients in the co-design in the clinic in the usual way, looking at questionnaires, but also doing some patient level reporting and patient co-design. So we had our transfusion practitioner and some of our CNSs meet with our patients as they arrived at the hospital and actually do a real-time study moving around the hospital with them, trying to understand what the experience was for them in their management of the anemia. So going back and forth to different clinics, going to pharmacy, going up to the day ward. And this enabled us to really streamline that pathway, making sure that patients had the correct information before they came up to clinic. So patients, actually, some of them weren't expecting to have a same-day infusion and they were happy to have that. Although for some patients that caused problems with having to stay around longer. So this led us to consider whether we could develop some more bespoke information around the pathway. This is just some patient shadowing, as you probably have experienced yourself, these sorts of comments. But we developed a video, which meant that patients who had been referred into the service for management of their anemia could access the video and have a bit of understanding as to what would happen when they came to the hospital, from going right the way through from the blood tests up to having an iron infusion. And this was with the aim of actually managing to improve access, improve compliance, and improve the experience of our patients. As part of the clinical practice group methodology, we develop outcome measures, and these are across 4 main domains. We look at clinical outcomes, we look at process measures, which tell us about what is happening on those outcomes. We look at what we call balancing measures, so this is whether there are any potential risks or safety concerns, and then we look at financial metrics as well. So for our clinical outcome measures, ideally, we would want to track people's well-being, quality of life, and energy levels. As a metric that was quantifiably accessible, we also tracked improvement in haemoglobin at 35 days post-clinic, and the proportion of patients who achieved a 10 gram per deciliter rise at 35 days. We also looked at prescriptions and the proportion of patients who had iron who were receiving it on the same day. We have patient experience scores, and then we also looked at the cost per pathway of patients receiving an iron infusion. And although I haven't actually got that data, we were looking to see whether we could in fact look at the cost per gram of haemoglobin increase, which as a metric which would take out some of the variation in terms of depth of anemia that people had and the sort of other investigations that were required. Balancing measures might include the number of patients who went on to have a red cell transfusion, perioperative, for example, and numbers of patients who were referred into the service. We created a dashboard where we could pull all of the data around haemoglobin together, and this is the first iteration of that coming out into an Excel spreadsheet, and this has now gone through into a Power BI type dashboard. So we could look by consultant, by service, and by intervention, the starting and the finishing haemoglobin, and then also what sort of tests people were asking for those patients at any one time. And when we started, there was, as you imagine, quite a lot of pathway variability. So we had a high proportion of patients who were microcytic coming through to all of the services, but quite a lot of variability in the proportion of those patients who went on to have hematinics, and similarly, actually very low numbers who went on to have B12 and folate. So that helped us in trying to understand how we could best deal with reflex testing of hematinics for our patients. One of the things that I'll highlight is that I personally felt that it was problematic and poor experience for patients to come up to have a full blood count, go away again, have their bloods reviewed, and then be called back for hematinics. And so we set up a process where the lab would retain the full blood count, and then if the indices were microcytic, reflex to an iron profile or a B12 profile if appropriate. I still think that is essentially a good way of managing the experience of patients in certain pathways. But what we found is that setting the automation for that was quite problematic, in that it would flag a lot of patients who might not otherwise have required hematinics. So we stood that down for most of the areas, but have tried to retain it, for example, for obstetrics, where managing an iron deficient anemia pre-delivery might be really important. So in terms of our metrics, we've looked at the clinic attendance, and we found that our new to follow-up ratio in this on the pathway didn't change. But what did change was the time to first follow-up. So we managed to see our patients and get them through their treatment and back in for a follow-up prior to discharge much more effectively. So the pathway, in fact, was shortened, and the number of people in the system, whilst remaining stable overall, allowed us to be seeing more new patients. In terms of the clinical outcome metrics, we looked at the shift in haemoglobin and the shift in iron saturation for people. So what you can see in the blue lines are the day naught values, and in the red lines are the values at 35 days. And the top panels are those before we initiated the pathway, and the bottom panels are after the pathway was initiated. And you can see that despite our best efforts in the top panels, patients were coming into the various anemia management clinics and 35 days later having very little shift in either their hemoglobin or their iron saturation. Whereas when we really streamlined the testing and the delivery, particularly of iron, the same day iron, and making sure that we had optimal prescriptions for them, we managed to shift the hemoglobin along and also the iron saturation, producing a durable impact for those patients whilst the underlying causes of their anemia could be investigated. We ran a number of PDSAs around the pathway, particularly looking to optimize the paper booklet that I mentioned to you. So how could we take this and produce something which eventually we could actually embed within our hospital systems? We trialed various aspects of dispensing, and we looked to see whether we could standardize recording of comorbidities, which is often poorly recorded in hospital symptoms. And we found that this not only improved patient experience, but reduced the time that a lot of our colleagues within this area needed to work per patient on producing the outcomes. So it reduced the number of pharmacy hours, the number of CNS hours in overseeing administration. It potentially, there's a chance of our increase in drug costs, but that was offset by the reduction in the time. I can see in the chat, somebody just asked, what is a PDSA? A PDSA is Plan, Do, Study, Act. It's part of quality improvement methodology. So it's a cycle of work that enables small improvements to occur serially within a pathway, as opposed to older methodology, which is very much, we do an audit, 6 months later, we try to make a big change, and then often we forget to continue the further audit. So we looked at the cost benefit of this. We took the various elements of the pathway and costed them, and we found that our costs went down by about 30%, even though potentially we were using 1 day iron infusions as opposed to the less expensive preparations, which are generally going over 6 infusions, for example. And then finally, we digitized this pathway within our electronic patient record. So we use Cerner EPR at the Royal Free, and it gives us an ability with some expertise that comes from Cerner or a digitization team to take the booklet that we have and then to embed it into the electronic patient record, so that as patients arrive, if their hemoglobin is low, that's flagged. So I log into my system, a patient is flagged as being anemic, I can launch the pathway. It will tell me whether the patient has already had the relevant blood tests. It will offer to request for me the blood tests which they may not have had. So if they've got a microcytic anemia, it will suggest a ferritin or tell me what the ferritin result is, and then lead me through the pathway eventually to the option of prescribing iron or making a referral, for example, to gastroenterology or to a lower GI clinic if we've got somebody who fulfills the requirement for a 2-week wait pathway for an iron deficiency anemia. And these are probably pretty small and you can't see them, but if people are interested, I can send you the link, because these are all created as videos within a Cerner style Wikipedia, so you can sort of run through them as a video and see what is happening there. So we've performed this clinical practice group methodology now across 65 pathways in the Royal Free, of which about 45 of them are already digitised. And we find this helps with compliance with the pathway, reducing unwarranted variation, helping us to collect the data because that's then automatically embedded. It also helps with the turnover of staff. So whilst there is some training required to help people to get onto the pathways, it allows us to mitigate potentially differences in the level of training and understanding in different clinical areas. So, for example, we have a pathway for the elective care of hip and knee replacements, which will look at all of the preoperative assessment, the operative care, the intraoperative and postoperative care packages, and if appropriate, will then segue into the anemia pathway should a patient be found to anemic at preoperative assessment. Our next step really is to take this pathway and say, is it good enough that patients are referred onto it when they have an interaction with secondary care? And in fact, could we not start this back in primary care, running it so that patients then started on the pathway by our GP colleagues who effectively could then manage it, and that would prevent some degree of referrals. We'd be available for advice and guidance, but I think it would improve the experience of some of the patients, and some of them would be managed effectively in primary care without a further referral. So I think it's upon me really to acknowledge all of the excellent work of the CPG teams and our patients who helped to co-design this, and I'm really happy to take any question.